All right, everybody, welcome to Advanced Clinical Concepts. My goal here is to get you to break out of your dental assistant and hygienist shells and start thinking about the world of ACLS in terms of being a clinician and caring for your patient. So as we go forward with this topic, we're going to go over, as we see on this page, the advanced clinical concepts. We're going to talk about these very specific medications, which are going to be very important for you to learn. We're going to talk about these specific therapies today, and we're going to talk about these particular conditions. Now, if you're way in the back and you can't read it, I'll just go over the meds real quick. We have atropine, adenosine, amiodarone, aspirin, epinephrine, IV fluids, which is a medication, and oxygen, which is technically also a medication. Some people might lump these fluids and oxygen into therapy, but it doesn't really matter for the sake of this course. So for therapy, this is specifically electrical therapy. We're going to talk about cardioversion, defibrillation, and pacing. And those are some of the treatments that you would do for some of the ACLS conditions we talk about. These ACLS conditions we're going to focus in on primarily involve tachycardia, bradycardia, ventricular fibrillation, asystole. We'll talk a little bit about what those mean. And the underlying goal or the purpose of any and all of these treatments in ACLS is to return somebody's blood pressure to normal. And the blood pressure needs to be normal in order to perfuse the vital organs, including the heart, the brain, the kidneys, and so forth. But primarily what the heart is concerned with is to reperfuse itself. Because in order for the rest of the body to live, the heart has to live to do its function as the pump, to deliver the oxygen and the nutrients. So the heart is, above all else, selfish, and so it'll try to fix itself first. And then the brain, in its desire to be selfish, wants to get all the blood to itself as well. So these two are the primary organs, the heart and the brain, that we're concerned about with these things. So with that said, we talked a little bit about some of the conditions previously. We gave definitions of tachycardia and bradycardia. We talked a little bit about hypotension and hypoxia. And for review, hypotension means low blood pressure. Hypo meaning low, tension is pressure. Hypoxia is low oxygenation. Hypo is low and oxy is oxygen. Tachycardia is fast heart rate. Bradycardia, slow heart rate. And then in terms of cardiac arrest, we talked a little bit before about how cardiac arrest means the heart is just stopped. It's arrested. Cardiac, of course, means pertaining to the heart, so cardiac arrest is an arrested heart rate. That could also be in the realm of myocardial infarction. Myocardial ischemia is not necessarily a cardiac arrest, but some of those things can lead to a cardiac arrest. As you look at your ACLS and you study, you're going to find that there are generally 10 reversible causes of cardiac arrest. And that's in your guidelines, it's in your algorithms, it's in your book, and they refer to it as the H's and the T's. So if you had a chance to go through your homework, one of the questions was identify 10 reversible causes of cardiac arrest. And what that is basically are the H's and the T's. So as you look through your ACLS manual and you look at the cards, you'll see a little thing that says H's and T's, or considering the H's and T's. And the reason why that's important is because a cardiac arrest, a heart attack, is commonly referred to that condition where there's a plaque in the major vessel of the heart, which gets blocked, reduces the oxygen to the area of the heart, which then causes the heart to stop beating, cardiac arrest. But the H's and the T's, those 5 or the 10 reversible causes, 5 H's and 5 T's, one of the T's is that particular cause of thrombosis or a clot within the major vessel of the heart. You can take a look at it at your leisure. There's going to be a course, a module coming up later about the H's and T's that's going to cover those specifically. We went over a little bit on Thursday last week as well, but some of the H's include hypoxia, hypovolemia. Hypovolemia means low blood volume. Hyperkalemia, potassium levels being a little bit high. Some of the T's include thrombosis, like pulmonary thrombosis, tension pneumothorax, and those sorts of things. We won't really talk about that right now, but those are some of the reversible causes. Okay. Now, when we look at our conditions, I started to list off this little table here. So the first condition we talked about is hypotension, right? Low blood pressure. In general, what is the definition of hypotension in terms of the blood pressure measurement? Anyone here?
90/60.
90/60, that's right. So less than 90/60. So systolic over diastolic. So if somebody's blood pressure is 89/61, is that hypotension? Yeah, I think technically. Although if you're getting that specific, it's a little bit difficult. Normally in your cases, you'll have, they'll really only just focus on the systolic, and they'll say they want to keep your systolic above 90. And that's in your ROSC algorithm, or the return of spontaneous circulation. But in general, usually they'll say the blood pressure is 80/50, 70/50, or something like that, and that's your key. Oh, that's hypotension. Treatment of choice, of course, as I said before, all of these lead to hypotension, except maybe hypoxia, but all of these can lead to that. So the treatment of choice is, you want to correct the underlying cause of it here. But if there is no underlying cause like this, somebody presents and they're hypotensive and you don't know exactly quite why, one of the treatments you want to give is maybe some IV fluids, right? And why is that? Why do you think you want to give IV fluids to somebody with hypotension? To increase the volume of the blood, exactly. So if your blood pressure is low, might be because maybe you've had a lot of bleeding or something and you lost blood volume. So you want to rejuvenate some of the blood volume with some IV fluids. In the return of spontaneous circulation, the ROSC algorithm, they'll talk about giving some IV fluid therapy if the systolic pressure is less than 90. And that's just to try to build up the volume of the blood to increase the pressure for a better perfusion of blood. Okay. Condition hypoxia. And what's the key feature of hypoxia for ACLS purposes? What measurement do you want to look for with hypoxia?
Less than 94.
Less than 94. Less than 94%. And that's using the pulse oximeter device. I think somebody had mentioned 40, but that's the end-tidal CO2 measurement. Not worried about that quite yet, but for hypoxia, low oxygen level, less than 94% on your pulse oximetry. So what's the treatment of choice for hypoxia? Oxygen. That's easy, right? Oxygen. All right. Now we're going to start getting a little something more interesting. Tachycardia. So what's the ACLS heart rate criteria for tachycardia or tachyarrhythmia? Heart rate greater than 150. There's a few types of tachycardia out there. We talk about ventricular tachycardia, and then there's more of the atrial tachycardia. Remember, the ventricles are the big chambers on the bottom of the heart that pump all the blood. The atria are the smaller ones. When we talk about tachycardias in ACLS, it's usually of the type that's above the ventricles, or supraventricular, SVT, specifically. SVT, supraventricular tachycardia. That's the primary one when we go down the tachycardia algorithms. Yeah, so she's just going to close the door for us. So for supraventricular tachycardia, or SVT, your heart rate is generally, they'll come at about 180 beats per minute. You'll have ventricular tachycardia, or VT, but in ACLS purposes, when we talk about ventricular tachycardia, that's usually more in the cardiac arrest area because the ventricles are going so fast, there is no pulse. But you'll see in your algorithms that ventricular tachycardia with a pulse is there, but we don't really focus in on that particular pathway too much for the ACLS class. So tachycardia, in this case, we're primarily talking about supraventricular tachycardia, or SVT, and that's the tachycardia that originates up in the atria. All right? Bradycardia. I'm sorry, before we go there. Treatment of choice for tachycardia or SVT is one of these medications here. Okay. Does anybody know the medication that you would use for SVT, supraventricular tachycardia? Anybody know that right now?
What is, I can't say. Yeah, the second one.
So yeah, so our choice is atropine, adenosine, amiodarone. Adenosine. Adenosine. There's another treatment that's not a medication that you can use for this tachycardia or SVT. Anybody know what that is? It's a particular maneuver. It starts with a V. Vagal maneuver, right? And that's, we're concerned with that, or we do the vagal maneuvers more when somebody's more stable versus unstable. Same thing with the medication. You give medications, you can give to them if they're stable or unstable, but primarily if they're unstable and they have this SVT, and remember before we talked about unstable meaning they have the signs of shock, they're hypotensive, they look sick, they're pale, they're sweaty and all that stuff, maybe altered mental status. What's the primary medication or treatment, I should say, for an unstable tachycardia? Anybody remember? From last week?
Cardioversion or
Cardioversion,
something?
yeah. Specifically synchronized cardioversion. And cardioversion is basically an electrical impulse to the heart to vert, and vert means to change the heart rate. Cardioversion is going to change the heart rate from this fast heart rate to ideally a normal heart rate. Ideally less than 100 is what you want to go for. So synchronized cardioversion, vagal maneuvers, adenosine, these are the primary treatments you want to concern yourself with for ACLS purposes for tachycardia or SVT. All right. Now for bradycardia, what's the key feature heart rate for bradycardia? Anyone tell me? Heart rate less than
50.
Less than 50. Now if somebody has symptomatic bradycardia and the heart rate is 51, sure. But for the most part, it's generally less than 50, usually 40 or maybe even 35 or something really, really slow. And we want to talk about symptomatic bradycardia. It's the same thing. Hypotensive, they look sick, maybe they're pale, they have some ischemic chest discomfort, altered mental status, unstable bradycardia. So what are the treatments for bradycardia for our ACLS cases? Atropine. Okay, what else?
Pacing.
Pacing. Very good. So the treatment for bradycardia primarily is atropine. One of the A's, we have 4 A's, really 3. Atropine is for the bradycardia. Atropine is designed to speed up the heart rate, or some people say will plus up the heart rate. Atropine will do that. And then if the atropine is ineffective for your ACLS cases and for your mega code, somebody is bradycardic, they're symptomatic, you give some atropine, it's not working. What you want to do is you want to move to transcutaneous pacing. Transcutaneous means through the skin. And that's where you'll have the pads on the chest, and you'll set the device for pacing, and they'll teach you that during the actual course. Don't have to worry about that right now. You set the device for pacing and it'll deliver a shock to try to get the heart rate up to maybe about 70 or so. We want to try to speed up the heart rate so that it will get adequate perfusion through the major organs. Now, of course, if they're hypoxic, you want to give some oxygen or something like that. Do you want to give them IV fluids? Some people will throw that in there during their mega code training, but for the actual ACLS course, for the checklist to pass the exam, don't worry about trying to treat hypotension with IV fluids if somebody's symptomatic bradycardia or tachycardia, because it'll just confuse the picture, and it's not a requirement on your checklist of things to do. Okay. Now we talk about cardiac arrest. Cardiac arrest is where the heart basically stops beating, And I've got a few different ways of thinking about it. The primary one we like to talk about first is this ventricular fibrillation, ventricular tachycardia, and it's pulseless. So they'll say pulseless VF, pulseless VT when you look on your algorithms. So ventricular fibrillation, can anybody describe for me what ventricular fibrillation is? Anybody familiar with that term? Anyone? We talked about it last week on Thursday, one of you guys? Ventricular fibrillation?
The heart is going like this.
Yeah. So it's basically the ventricles of the heart are kind of doing this motion. They say it's like a bag of worms. You know, you just kind of, it's just the muscle is not coordinated and it's not pumping effectively. It's just like fibrillating. Okay. Using the word in the definition, it's just fibrillating. And then ventricular tachycardia or pulseless ventricular tachycardia, that's where the heart ventricles are beating like maybe 200 beats a minute. And you'll see it on the monitor as a certain pattern. We'll get into that later, but there's no pulse associated with it. And so that's your cardiac arrest. All right, so VFib, VTAC, key features. So ventricular fibrillation, it's just kind of a bunch of squiggly lines on the EKG and there's no pulse. And then ventricular tachycardia is a much more consistent pattern of just this up and down appearance. And the treatment of choice for VFib, VTAC, anybody tell me? What's the treatment of choice? Defibrillation, yeah. So if it's ventricular fibrillation, you want to defibrillate, right? So defibrillation, and that's the shock that you always hear about, and that's what the AED is going to deliver. It's going to deliver a shock. It's going to try to defibrillate. What's another treatment of choice besides? I didn't write it on there, but you have defibrillation. What else? Do you want to give this person? Epinephrine. What else? Amiodarone. Is there anything else besides that? I didn't write it on the board here, but also that's your CPR, you know, chest compressions, breathing, and all that stuff. So when you're having your cardiac arrest due to VFib, VTAC, you want to, you know, chest compressions, shock, epinephrine, resume chest compressions, shock, epinephrine, chest compressions, shock, amiodarone, chest compressions, and so on and so forth. It's a shock drug cycle. Okay. For asystole, asystole is characteristic as what on the monitor? Does anybody know? Ever seen that before? Asystole? It's your classic flatline. So when you're watching a TV show and somebody's like, you know, in the hospital and they die, all of a sudden you hear beep, beep, beep. That's the, you know, the little flat line that comes across, and that's how everybody knows that they're dead. It's because they have asystole. Systole, remember, is the contraction. So A means without, so without contraction. So basically the flat line, if you will. Okay. So treatment of choice for asystole. Do you want to give defibrillation shocks for that particular condition? Anyone?
Yes.
The answer is no. Okay. So, because there's nothing to defibrillate. Asystole, which is epinephrine. And so in this case, you give epinephrine, CPR, epinephrine, CPR, epinephrine, CPR until you see a rhythm change or you decide to call it. Okay. Pulseless electrical activity, PEA. Can anybody describe what that means? Anybody want to talk about that?
Something electrical activity.
Yeah, so you'll see electrical activity on the monitor, but there is no pulse. Typically, it'll look like, you know, your standard EKG rhythm with a P and a QRS, but there is no pulse. And so for PEA, they'll try to stump you on that during the ACLS thing. They'll say, oh, look, there's a rhythm on the monitor. You check a pulse. There's no pulse, they're in PEA, you resume CPR, and you treat PEA and systole the same. You know, you're not going to defibrillate it. You're going to just go and treat with epinephrine and CPR, just that continuous cycle.
What does that stand for again?
PEA, pulseless electrical activity.
How is that possible to like generate a rhythm like that and it's not doing? That would really confuse me, I think.
Yeah, so the question is why? How is it possible for the PEA to occur? So in other words, the heart is sending its signals to try to contract the muscle, and its muscle's not responding. Okay. Why does it happen? It's in the book. We'll talk about that later. But the key with that is you'll see the little rhythm on the monitor. You check a pulse, no pulse. You resume CPR. Okay. What else? Questions?